Welcome back to Health in Today's Woman. Tonight we're talking about a very interesting topic in strokes, cerebrovascular accidents. As Dr. Witt had mentioned that they don't particularly like that term, but just any type of neurologic impairment. In our first segment, we really looked at some of the risk factors and some of the signs and symptoms. In this segment, we're going to take a little bit of a turn, and we're going to look at that patient who is having those signs and symptoms and look at some of the new treatments that are available for those patients. Now, one of the things that we want to make sure we really hit in this segment is the fact that if you seem to be having these symptoms, we want you to call 911. And John, this is something that when you first talked about doing this show, you wanted to make sure that we communicated. So I want to give you a second here to communicate. Why is it so important to call 911?
Right. Well, and I'm sure we'll talk about this more, but there are treatments that we can offer for stroke that really depend on getting to the emergency room quickly. And not only that, but getting to a properly equipped emergency room. And so the emergency medical system, which you access by dialing 911, is really the only way that the average person knows where to go and can get there as quickly as possible. There's a finite window of time that we have to treat patients, and unfortunately most of those treatments are not available to the majority of patients because they simply don't get to the emergency room quickly enough.
Well, we're going to take a second. I want to introduce Sylvie into this conversation because one of the things that's great about Middle Tennessee Medical Center Murfreesboro is we have a stroke program, and I want you to just very briefly explain to me what a stroke program is.
Well, briefly, a stroke program is an organized approach to taking care of stroke patients, which means we're using all the latest research and guidelines to march a patient through care from beginning to end, and they're all getting all the same basic necessities of stroke care. And along with that there's education that goes along with that of the patient and the family and community, those types of things. So when a patient hits our doors, we have staff that are trained and know how to handle a stroke and how to take care of a stroke.
And that's very important because as John and I had mentioned a minute ago, is this whole idea that stroke is kind of a window. We have a window, much like a heart attack as we used to think of years ago. We're starting to look at stroke much more like heart attack. Is that correct?
That's right.
And we're starting to see, what is this window? I mean, what are we looking at as far as time window that we really want somebody to be seen in the emergency room after stroke?
Well, the first thing to know is that the earlier the treatment, the better. And so even though there is a window, we take every effort to try to treat people as early as possible, even within that window. So the most commonly used and the only FDA-approved treatment for stroke acutely is a drug called intravenous TPA, or tissue plasminogen activase. And this is a drug that's given by vein, and the window of treatment is typically 3 hours. That's where the evidence for effectiveness is the strongest. Now recently there's been some new guidelines suggesting that we can use this up to 4.5 hours, and so in fact we do that as well. But the goal is really to treat patients as early as possible. So treating at 1 hour is superior to treating at 2 hours, and that in turn is superior to treating at 3 hours.
Now, I want to kind of walk people through so that when they do go to the emergency room for a stroke, I want to kind of get an idea. Give me a little bit of an idea when you hit the ER, what can they expect?
Right. Well, they can expect to be seen by an emergency room physician who will do a neurological examination, try to determine if a stroke has in fact taken place. That's probably the initial goal. Secondly is to get a scan of the brain, usually a CAT scan, that tells us whether there's been bleeding into the brain or whether it's the type of stroke that's likely to be due to a clot. Along with that, there's blood that's drawn to look for blood disorders and other conditions that would influence how that patient is treated. And then lastly, when all that information is available, a discussion is made at the bedside about the risks and the benefits of treatment, whether that particular individual is within one of those treatment windows, and what's available or reasonable in that particular situation.
And I would think that's one of the great things about having a stroke program is you're getting people that are educated and used to seeing stroke patients and are good at being able to communicate with you what the risks are, not just the physicians, but also nursing staff and other. Is that correct, Sylvia?
That's correct. We have focused a lot on getting our nursing staff, especially in the emergency department, comfortable and educated on stroke and how to take care of it, especially those that come in that early window.
Now, what about the patient who may not be in that window? That's one that's,
yes.
I think, is such an important one because they say, well, I'm outside that window. Can I still benefit from going to the emergency room? What's the question of that?
Right. Well, in the few hours after that traditional window, there are actually some additional treatments that may be available to a small percentage of individuals. Those treatments involve either delivering that same drug by way of a catheter directly into one of the arteries of the brain, or by going in with a device that actually extracts or retrieves a clot out of the brain. And so those are obviously much more invasive and more technically difficult treatments, but up to about 8 hours or so, those kinds of treatments may be available. After that point in time, for most people, the care is a little bit more supportive. We start to initiate the evaluation that we do for all stroke patients during those first few days of the hospital. But it's still important to get to the hospital early because there can be early complications to stroke. There can be aspiration, difficulty breathing, there can be swelling of the brain, there can be all sorts of things that happen. So even if a person feels that they're not in that very early, say 3-hour window, it's still important to get to the hospital soon.
And something I want to make sure people understand, aspiration is where you take the stomach contents and put them into the lungs and can cause all kinds of problems and infections in the lungs and stuff like that.
That's right.
But I think that's very important. I think you brought up something that even though you may not be in that window, we can provide supportive care. And so can you address a little bit more on what MTMC does as far as supportive care and how they address that in the patient who probably is not there exactly in that window?
Right. Well, once those patients are seen and admitted through the emergency room, that's where we do a lot of different things. A lot of our tests are to screen to see if we can find the mechanism for the cause of the stroke, and that's part of secondary prevention or preventing it from happening again. And then also trying to prevent complications such as aspiration pneumonia, making sure it's safe for them to eat orally if they've got a stroke that has involved the muscles in their throat, getting therapy started as quickly as possible to try and return function, and also to start educating the patient and family of what to expect next, and look for any other problems or any other medical conditions that need to be treated at the same time.
That's great. We're going to take a break now. When we come back, we're going to talk a little bit about how to rehabilitate the patient who has actually already had a stroke. We'll see you after these messages.